Good afternoon. Welcome back to Grand Rounds today. Please remember to sign the attendance record at the back of the auditorium, and also please fill out the program evaluations, and please give the CME committee any ideas you might have in regards to future topics or future speakers. Reminder that we will be taking a holiday hiatus for 2 weeks and then reconvene on January 8th. Today, it's my pleasure to introduce Dr. Selden Spencer. Dr. Spencer is board certified in neurology and also accredited in neurosomnology and polysomnography. He has been a frequent and excellent contributor at Grand Rounds, and we're pleased that he was able to accept our invitation today to come and update us on dementia and mild cognitive impairment. And please join me in welcoming Dr. Selden Spencer.
Thank you. Well, good afternoon. Let's see, I'm in the right place. I've got the right things. Okay. I went back and looked at my old talks, and it turns out that I've done this every 2 years. So I've retrieved stuff from 2012 and 2014. Last time I did it was 2017, and since I'm going to retire in 2021, you may get me one more time in 2021. We'll see. But I do want to give a shout out and a thanks to Tim Hextra, who helped me with some of the audiovisual here, and then Lori, who helped me, Lori Baker, with retrieving some obscure articles that I'm going to refer to. Yeah, and this is going to go through a pretty standard course for the first half of the talk, and then things are going to get exotic and weird toward the end. But that's the nature of the beast. I mean, things are getting very strange out there as far as how the brain works, how the brain gets bad, and how we can potentially fix it. So the outline is as follows, pretty standard. And I'm going to use some of the cases that I dealt with. Actually, I picked cases just from the last 2 or 3 months just to have it fresh in my mind, and this will be an opportunity for me to talk through how I approach these patients. And I need to give a disclaimer right out front that my pattern and what I tell you is not necessarily representative of the neurology department or representative of my partners or the United States. It's the way I approach it. So take that into account. So we're going to talk about that. I'm going to reintroduce the idea of presenile dementia, and we're going to talk a little bit about mild cognitive impairment. And then what's new is that I'm going to talk about normal cognitive impairment, or normal cognitive aging. So guess what? There is such a thing. You aren't as smart when you're 60, 70, 80 years old as you were when you were 20, 30, or 40. And what is that all about? And there are people trying to sort that out, and it's kind of interesting. And then lots of very interesting thoughts about pathophysiology. Okay, so you got to go through this slide. It's a big problem. And I tried to sell the idea that it's not as bad, that it's kind of waning, but it's not. And it's about 6 million people in the US, 10 times that roughly, have preclinical diagnoses, and many of those will go on to, easily half of those will go on to dementia if something else does not take them out. Basically, I always use the term half of people over 80 have some cognitive impairment or frank dementia. It's actually more like 40%, but it's easier for me to remember 50. And it's kind of moved up to the 5th leading cause, and a huge cost, not just the cost of caring for that patient, but the cost to the caregiver and families. So, this is a slide from 2012, and I like to emphasize this. It's very important to use the right term. If you're going to say that somebody is demented, you imply that they have impaired memory, but they also have one other sphere of cognitive performance that's impaired. Maybe it's language, maybe it's behavior, maybe it's visual spatial recognition. And then finally, the key word is they can't function. And I've been to conferences, and I always ask them, well, how do you define that? And this is pretty sad, but they always say, if you could leave this person alone for the weekend, would they be okay? And if you have some suspicion they would not be okay, then you don't want to, their function is impaired. I'll go through, we do have functional assessment questionnaires, but again, you have to kind of get down and dirty and talk to the family and try to see if you can sort that out. MCI is just, there is just some memory problems primarily. And then preclinical is there's really no sign, but there's something going on. This is a review that was just very recent in October, and I'm not going to be rehashing this. This is 4 or 5 pages. It's 10 pages, I guess. Very thorough. And if you want to get that, you'll learn everything you need to know about what the current thought is about dementia. I'm not going to go through these variants of diffuse Lewy body dementia or frontal temporal dementia. I'll give you the high point. Lewy body, there's some element of Parkinsonism and hallucinations. Frontal temporal, guess what? Frontal means behavior. So if there's a lot of behavioral element to their memory impairment, you think about frontal temporal dementia. I haven't changed my approach to doing testing, and God bless all the primary care doctors out there. They usually do all this for me. The only thing I play around with is I usually prefer to have an MRI of the brain rather than a CT. So at this point, I don't do CSF testing. We do not have access to PET scans for dementia. Nobody will pay for that. So from my perspective, just do the B12, thyroid, look for obstructive sleep apnea, look for everything else in their general health that might bear on this. There are many social and medical options to slow progression or at least compensate, and I'm not going to go over all that. You're all familiar with donepezil, you're all familiar with memantine. These are drugs that I will introduce and you will introduce in the care of your patients. What's a little new is this from the Academy of Neurology, is that they really want to do screening on a regular basis. I don't know what's magic about 65, but if you're a neurologist and you're seeing somebody for peripheral nerve disorder, you ought to be doing a screening of their cognitive performance at age 65 to identify more people that have mild cognitive impairment so that you might be able to impact their life. All right, and it's funny, they have 6 items in this, and I gave you the reference down there, 6 items, and one of them was looking at anticholinergics. So, I mean, that's old school, but they thought it was important enough that you, some of the bladder medicines, you want to make sure that that's not an exposure or a problem for them. Okay, so again, I'm going to take you through the way I would approach a patient. This person was referred, and it was at the insistence of the wife that they came to neurology. And what the wife said is that he just keeps asking me the same question over the past 2 years. So I tell you, my routine is that I have a good cop, bad cop routine. My nurse, Shelley, God bless her, goes in and does the slums assessment, which is sort of timed, and I'll go over that shortly. And it's pretty hard. And it's very stressful. Quite often I walk into the room and the patient's in tears. And then we got to calm down and I just say, hey, tell me about yourself. Tell me what your career was, you know, tell me about your family. So this is a guy, he knew he had 3 kids, but he couldn't remember the names, couldn't remember where they lived. So there's something wrong, right? We all agree. The wife said he was a former welder. He retired in 2010. This guy still goes out and hunts. He mows yards, moves snow. He did have a severe head injury at age 26, which I thought that was kind of interesting. Past medical history, low back pain, depression, and mother with dementia, died at age 77. So that's also interesting from a genetic perspective. Habits are as follows. You know, you always ask about alcohol and other bad behaviors. He had a wide base gait, but he's very fast, good balance. So I don't know why he was wobbling like that, but at any rate, everything was normal. I didn't find anything. Now, his slums test generated a value of 7 out of 30, and I gave you the normal, abnormals, MCI, and less than 10 is considered demented, but I didn't feel good about calling this guy demented. I said etiology unknown, and I actually raised the question of chronic traumatic encephalopathy, the football injury, because he had that bad head injury. Maybe it's Alzheimer's mixed. And then I do the image and get together. This is his image. And what I get out of the images are two things. One, I'm kind of generally interested in atrophy and loss of volume of the brain, particularly down here where the hippocampus is. And I'll show you other slides going forward. This guy's pretty good. One other thing to show is quite often, anybody over 60, you start seeing ischemic changes. He's got just a little bit back here, but this is really pretty good. So here's another one. This is trying to be gender neutral, 75-year-old woman with a year of repetitive questions to her husband. It's funny, same thing, repeating questions drives him nuts. She is unable to recall her from her work or where her two daughters live. That's all you need to know. This person has got serious problems. She's a retired beautician in 2010, also worked at a cookie shop at one point or another. However, she has a significant past history of hypertension, all these vascular things. I said, well, that's a concern. Family history didn't help, no bad habits. And her slums generated a value of 9 out of 30. Now, again, I told you anything less than 10, you say, well, technically that's a dementia. So I'm comfortable calling it dementia, but I think that this is going to be more vascular than neurodegenerative, more than Alzheimer's. So all our labs were fine. This is her image. And this is different. If you remember the coronal section, there's a lot of ischemic changes. All these little white spots are ischemic changes. And this is a blowout. This is the temporal horn, and this big black area is communication with their lateral ventricle. So there's tremendous atrophy. This is neurodegeneration. But there's also a lot of vascular changes. So in terms of thinking about what's going on with her, yes, she may have the Alzheimer pathology of neurodegeneration, but she's also got circulation problems. And as I'll tell you later, the two are not that dissimilar. Circulation is fundamental to this whole conversation. All right, so on our EPIC system, if you want, you can have this little blue box where you say cognitive impairment assessment, and it has all these wonderful things you can open up, including the slums. And I'm going to show you that, and well, these are the domains on here written out. What we particularly focus on is trying to get a cognitive assessment, and as I was telling you about the functional assessment, trying to assess that. All the other things, some are research-based, but of note is many of them are looking at the caregiver, because at the end of the day, what's going to carry this game is the caregiver. This is the slum up close and personal, and more and more, I really like it. The reason I like it is it hits memory 3 different ways. You have to do the kind of remembering words, you have to remember numbers, and then lastly, you tell a story, and they have to remember things out of the story. It's a very effective way of assessing memory. So I'm happy that we've got that. I didn't give you the scores down there completely, but it also divides it out whether you've had a high school education or less than high school. So this is also from an old talk, but I want to stress it because this is where I come from. On the left is August Dieter, who died at age 51 in Germany in 1906. This is the index case of Alzheimer's disease. She had the diagnosis 5 years, or at least she was institutionalized in 1901, died in 1906, and was autopsied, and Alois Alzheimer, exotic, Congo, die, placed it in vein, and had all this unusual pathology that we reflect on and try to figure out. On the right is a guy who died about 10 years before I started residency at WashU in St. Louis, and he was part of a Nobel-winning team in the 30s that did all the initial work on electromyography and nerve conduction testing. Up to his death, nobody was aware of him having any problems. On autopsy, he has tons of amyloid. Okay? So this guy, no mental problems, pathology. This gal, terrible mental problems, lots of pathology. To me, this is a problem of knowing what the hell we're talking about, okay? So old school is new school. What I've read recently is we used to use the term presenile dementia. And for this audience, let me just kind of emphasize, if you have somebody young, and by young, I'm saying 40s, 50s, even 60s, and they're slipping on, red flags. You got to be out there. You got to look into this, and they'll probably wind up in a tertiary center trying to figure this out. There's lots of weird paraneoplastic disorders that we have to identify and try to work on. But it turns out that there is a little bit different pathology in this presenile dementia, and I'll get to that in a moment. Younger females in particular, mainly they don't get so much in the hippocampus and more in the limbic as far as their tau distribution. So again, you get amyloid, you get tau, and I'll go over that, and then you get stupid. All right, so why age 65? I don't know. But again, young is very important. So this is the signature slide from a lot of stuff done through Mayo, and this is talking about tau, all right? Amyloid is over here, and that supposedly hurts the cell, and then you get tau. And the point being that actually the amount of tau goes down with age on autopsy studies, but the risk of dementia goes up. So it's a little bit puzzling that way as to what's doing what. And the age of onset as to where you see the disease quite varies. So all these variables, that's the point I want to make. You have amyloid, you have tau, you have different versions of tau, and they are not unique to locations in the brain. So you have at least 3 variables that you have to play with when you're thinking about dementia. And I know this doesn't boil down to the individual cases very well, but it's something that you need to be aware of. That's where we are in this whole thing. And then the second part is, what is the rate and spread of these diseases? It's not like it goes to one part of the brain and it's done. It evolves, and how that happens is weird. And of course, my favorite is, how does this disrupt the connectome? Because that's the part of the brain that seems to make us work. All right, so you're kind of getting into the old lumper and splitter issue. And this, to bring that home, this is for chronic traumatic encephalopathy. So usually starting up more toward the dorsum of the brain and then spreading down into the hippocampus. Whereas Alzheimer's usually starts down here and spreads, and that's as far as tau spreading. All right, so now we're going to talk about MCI. And again, this looks great. Your black and white looks terrible, but the red means that there's lots of sugar being used, not so much here in the myocognitive, and it's terrible with Alzheimer's disease. So that's the pathology that we're in. Here's a couple case histories. Okay. Which one is this one? All right, this is an 80-year-old retired farmer electrician. Yeah, I just saw him recently. He had a head injury in 2017, so you kind of wonder, well, what did that have to do with anything? But he's had all these other medical problems going on, and depression and dementia in his mother. And he generated slums of 25, so he's not that bad, but he's a guy that we got to pay attention to. He's aware something's wrong. And we can document it. This is his MRI. The point here is, again, he's not a blowout here, but he's losing volume, and he's sure as heck losing volume up here. But he doesn't have a lot of ischemic change. He's looking pretty good in terms of circulation. So this is a guy who we're going to employ all these different drugs to try and keep him function. And again, just decide is donepezil and memantine make the brain work harder. They don't fix any underlying pathology. They just make the brain work a little harder. And that can be a good thing. That can help. Here's another guy, and this goes back to 2012. So I'm 7 years later seeing this guy every 6 months. He's a retired farmer. He forgot to remember why he went to a town. He did it twice in one day, and he's just really mad about it. So we checked him out. Unfortunately, this is mental status, which we're not supposed to use that word, but that was the value of his test, which isn't good, 23 out of 30, but it's not that bad. This is his MRI from 2012, and you can see his volume in the hippocampus is quite good. He does have some ischemic changes. So focus, if anything, would be on doing your best for the vascular system. Now, this is 2019. The guy was out in the field helping a farmer harvest. So he's doing pretty good. He's still very likes to make jokes. There's a German term called Witzelsucht, and I think you'll see this in patients. They just want to make a joke out of everything. It's just kind of weird, but that's a very frontal lobe identifier. And so I call him now, with a slums of 10 out of 30, demented mixed vascular. He lives with his daughter, stays in the basement. He doesn't go to the country western concerts anymore. He doesn't walk his grandkids to the stop, but he still goes and helps farmers and goes to the cafe to have coffee. So we'll stay in touch with this guy, just emphasizing, but this is a guy who's progressed under my watch. I can't do anything about it other than try to keep him safe. Now, we do need to look. You do need the imaging. I can tell you the story of this patient. She had some mild cognitive impairment, and she was rushed over because of this meningioma that was here, and we didn't do anything. Then a year later, it's bigger. We have to do something. So surely getting rid of that meningioma made her better, right? No, did not. All right, so again, dementia doesn't suggest the pathology is just clinical. Alzheimer's disease suggests the known pathology and clinical condition. Truly, I think it's presenile dementia. It's Augusta Dieter. If that helps the family and it's not unlikely, then it's okay to use the term Alzheimer's disease, because that translates into neurodegeneration. And it'll help them to work with the Alzheimer's Disease Association for all the wonderful things they do. So Alzheimer's suggests a specific amyloid tau spread, but some dementias are pure tau, like frontotemporal dementia is mostly a tau disorder, and some are all amyloid. So what do we do about preclinical and cognitive aging? I found this very interesting, and here's a couple of references. They have about 9 cognitive phenotypes that they've identified, some of which are more likely to lead on to dementia. And this is really, maybe when you're in your 40s or 50s, we're going to try to figure that out. But there's been stuff out there for a long time. I've referenced a number of articles. Even your grades in middle school can predict dementia. Your personality can predict in adolescence. There was a recent talk about people in their 20s that have income insecurity. They're more likely to be demented. So there's all these various things out there. So brings me to speed and cognition. And I've showed this slide before. One of the most predictive things is your rate of gait. This is several studies all over the world, Finland and UCLA. You don't want to be in this quadrant down here. There's 4 quartiles of gait speed, and if you're in the slow group, you're going to get worse in all these parameters that reflect cognition. Lots of other biomarkers, tons of articles that are going to come out. At this point, I don't think any are ready for prime time. I hope you don't try to go order them. Nobody's going to pay for them. But they're of interest. And I've talked about neurofibrillary light chains, also known as NFL, easy to remember because it's important in traumatic encephalopathy, NFL, right? But the A-beta, there is going to be a serum test to measure amyloid in the brain. What are you going to do with that? I'm not sure. It would be of interest maybe, but I'm not going to do that. Insulin-like growth factor is getting a lot of popularity. More intensive psychometric testing to predict where you're going. Imaging is also, you can measure tau, you can measure amyloid, you can measure atrophy, you can measure glucose, and there are people proposing this amyloid tau neurodegeneration sequence software. I don't think we're ready to do that. I'm still interested in olfaction, but this is a Dutch program that is just absolutely comprehensive, where they take all kinds of demographics, all kinds of psychometric testing, all kinds of serological testing and imaging testing to predict people. We're not ready for that. We ain't doing it here. You go to Mayo or University of Iowa for that, if they're going to do it. So, brief talk about genes. Apolipoprotein E is still a risk factor, but it's not predictive. It influences lipid metabolism. There have been GWAS studies that have 30-plus ones that they think are important, but they are not making it. The length of the telomere, that is your the gene regulator. There's a gene that they're looking at that. TREM2 has a lot to do with microglia. Microglia is our immune system in the brain, and a lot of research in trying to keep that immune system settled down so that the person doesn't get more stupid as they go along. mTOR is also something, it's a gene that seems to have tremendous influence on synaptic plasticity and cell survival. However, so this is my reflection on speed, and I was telling Steve before he left, this is a really neat article, and Mike and I already have had a little disagreement about it, but the idea is that maybe speed is your perception of speed, okay? So if there are a couple cells that communicate between the entorhinal cortex and the hippocampus that seem to tell you whether you're going fast or slow. So you have an old person who's just kind of walking along slowly. That's probably the brain says, hey, you're walking just fine. You have somebody else walking fast, and that's the way it feels normal. I didn't want to get into what is the neurobiology of memory. There's a wonderful journal you can avail yourself. I think it's all about synaptic strength and repair. So here's mTOR. I didn't want to do every one of the genes. And you can see in a nice mouse model that a normal person has lots of sugar being used up here, but as you get old, it's not doing so well. You block mTOR and everything resorts to normal. And these are the mechanisms they talk about, both in terms of inflammation, oxidative stress, on and on and on. But when you talk to the genome, I'm always, maybe because I don't understand genetics, I'm not that impressed, because you got to talk about genetics. You have to talk about transcriptomics. You have to talk about proteomics. You have to talk about metabolomics. You have to talk epigenetics. And as has been said frequently, your zip code is more important than your genetic code. You understand? And right below that is adverse childhood experiences predict when you're going to die, what you're going to die of. You grow up in a household where you watch your mother get beaten, or you get beaten. You grow up in a household where they're not sure of food, you're not sure whether you got a place to live, you're not going to do well. And it may be dementia, it may be something else. So, what is the pathophysiology of Alzheimer's? We're still obsessed with amyloid accumulation and intracellular tau, leading to cell death and spread to other parts of the brain. But the new insights have to do with how to remove amyloid and what can, all these factors which allow it to collect. There's an article I'm going to reference that talks about vascular endothelial immune clearance factors, genetics, and herpes simplex virus 1 doesn't go away. So here's the pathology. This is the amyloid plaque. That's the tangle. This is in brain tissue. And we think that this amyloid precursor molecule, which is actually probably has a immune protective role, gets cleaved in the wrong way. You get this junk accumulating around the cell, and the cell kind of gives up, and these fibrillary neurofibrils become the plaque that we talk about. All right, and so Jack's hypothesis from 2012 is that you get the collection of amyloid, and then you get the collection of tau and cell death, and then you have cognitive problems. This is the new iteration. This is from Hachinsky, who has been beating this drum for a long time. It's the brain and vascular that goes sour, leading to the amyloid. The amyloid is just reacting to all the junk that's coming in, tau and then cognitive impairment. And I've shown this slide before, all the different varieties of small vessel disease. I showed you a couple of images where you saw small vessel disease, but there's a lot of different varieties in there. And so you have a bad artery, an endothelium that doesn't work well, all this junk gets out there, the microglia gets crazy and starts causing trauma to the oligos, to the neurons, to everything. So vascular risk factors lead to impaired clearance, more tau, A beta, more vascular dysregulation, and more synaptic dysfunction. My favorites: gut microbiome, senescent cells, the vasculature, immunosuppressant, and microglia dysfunction, and then sleep dysfunction. We'll talk about this here. So again, vascular dysfunction, leakage cause problems. This is senescent cells, so I want to spend a little, because this is important. They're starting a clinical trial now about senescent cells. You all familiar with senescent cells? This is crazy. Guess what? Some cells don't want to die. Be endothelial cells, could be a neuron, could be an astrocyte. They get old and they don't do autophagy, which is cell death. There's a program in our genetic code that leads to the cell to die. Well, they got a way to figure this out, and they stick around. And guess what they do when they stick around? They don't do anything. If you get an immune cell, a T cell, and it's senescent, it just sits around and complains. It's kind of like old white guys, you know? And it's a fascinating idea. So there are ways of killing them, and they are using cancer drugs to kill them, and there are clinical trials applied to Alzheimer's disease. Yeah, so senolytics, so killing senescent cells. This is in a tau rat model, and you can see that the control has normal, but when they get a lot of tau, they don't work that well. You give them the senolytics, and they do a little bit better. All right, what about the gut bacteria? Guess what? An Alzheimer's person does not have the same collection of bacteria in their gut as do you. What's that all about? Is that cause or effect? It's very interesting, and it's ripe in every area of neurology and biology going on. I'm not going to spend a lot on this because I don't understand it, but this is going to be a factor that bears on biologic testing, looking at extracellular vesicles. So again, things are not going well and they're floating around in the blood, and it's a marker for things going bad. So let's talk sleep. And I apologize, Eddie, see you there. I know there's no such thing as stage 4 sleep, but I wanted to use this one because this shows delta frequency very well. And we're going to get biophysical here real soon. Delta frequency is important. This is the old sleep hypnogram where you're awake, go into slow wave sleep, and then you progress through REM sleep and shallow sleep. One thing that's fundamentally happening as you get older is slow wave sleep goes away. How can we get slow wave sleep back? Is it important? Well, I'll tell you it's important. Sorry, I'm going to do a little drift into circadian. You got two things that monitor sleep. One, your homeostatic drive, and the other is your circadian rhythm. And I thought this was just fascinating. You can take out the suprachiasmatic nucleus in a rat, and they don't get old very fast. You get rid of the clock, they don't age. Isn't that interesting? Well, I'm not proposing that we get rid of our clocks, but that is another variable in the mystery that's going on here. But the big thing is in sleep, we get rid of the junk in your brain. It's all about lymphatic clearance. And if you don't get rid of the junk in your brain, you do get amyloid collecting. And this has been shown frequently in animals, primarily, that you can clear amyloid through good sleep. So sleep and dementia, clearance of amyloid. It's okay to collect it, but you got to get rid of it. Sleep is key to consolidating memory. That's been known for a long time. So poor sleep impedes clearance. Sleep is impaired, key for synaptic plasticity and immune equilibrium. We usually don't get enough sleep. We can hammer on that over and over again. Or optimal sleep. The virtue of slow wave sleep leads to optimal clearance. And remove the clock. We're not going to dwell on that. All right. So here's your lymphatic clearance. It's alongside vessels, and it's sucking all the stuff out of the interstitial circulation, out of the brain. This is a fascinating article which suggests that the peak of your delta frequency is key to the clearance of the spinal fluid. That's a documentation that slow wave sleep is very important. So I guess I wanted to show you what, that's 4 cycles per second. That's the good stuff in your brain. You want to have that. And if you have that, then you do this. Get the point? All right, move on. Oops, sorry. Got it. Stop. Help, help, help. All right. So I got to say something about infections. This won't go away. And you can find fragments of DNA of herpes simplex virus in tau molecule, and it just won't go away. It's still out there. And it's interesting in the sense that they're thinking about trying to develop a vaccine for herpes simplex virus 1. And then the whole thing about immunosenescence, and the whole concept that our brain, the function of aging brain is it's inflamed, inflammaging. And so it has to bear on our immune system. Okay, so what is our treatment? So as before, we used it in Episil and others to try and make the brain work a little bit harder. We know that staying isolated and inactive is bad. You got to keep people out, moving around. The Mediterranean diet clearly is beneficial, especially olive oil. Physical activity is good. I love this story. I don't share that article, but you got a little time with the patient. Just tell them this. You can take a bunch of mice and you train them to go up the stairs to get their food. You take 20 mice over here, and they go up and down and get their food whenever. The other 20 mice, they have to wear a pack with weights. Guess who gets smarter, who does better? The ones carrying the weights. Okay? Just share that with your patients. That may convince them that they need to do something. There will be approval, most likely from the FDA, for antibody to amyloid, but probably doesn't do anything, but they'll make some money off it. Clinical trials with senolytics, deep brain stimulation. Now, I haven't talked about this. I will at the very end. You can put a probe in the brain near the fornix, and you can have people retrieve memories, modify memories, change the emotional context of memories. It's totally freaky. It's very cyborg. It's very weird. But there are clinical trials with deep brain stimulators for cognition. And the photomodulation has to do with light and sound frequency now in the gamma range, not in the delta range. And you do this in mice, and according to protocols, hour exposure in a 24-hour period for a mouse, you can see growth of volume of the auditory cortex or the visual cortex. So developing in ways to improve cognitive reserve, that's something that you develop probably when you're in 5th grade. Fecal transplants are talked about, playing with bacteria. Antivirals have not helped. Trying to inhibit microglia, there's tons of work going on with that. Okay, so again, this is the old Finnish trial, also done at Rush, UCLA. You get people in these good habits of exercise and diet, they do better than the control group. Not great. This is where your frontal cortex and cognitive reserve exists, helps you cope. And this is about the photostimulation. Okay, so I'm almost done. What time is it? Okay, good. This is great. So I have to warn you ahead of time that I don't want to cause a seizure. This is fast frequency. And this is the frequency, roughly the frequency, that the mice were exposed to that led to the improvement of their volume of brain tissue. And that would be fun. Do that for an hour a day. What do you think? All right. So we do have enough time, and I've thought about it. And I do want to do a summary, and there'll be one slide with a summary. But I was kind of inspired by the musical Hamilton when Aaron Burr talked to Alexander Hamilton, and he said the following. He said, talk less, smile more, don't let them know who you are for or who you're against. I'm telling you, eat less, sleep more, maybe you will block your mTOR. Walk fast, lift weights, maybe inflammation you will abate. Sleep more and just right, suck all that interstitial junk right out of sight. No sweets, no meats, perhaps then the same words you won't repeat. Eat less, and like a Greek, olive oil may block your endothelial leak, and then your microglia won't freak, and you will be at your peak. So, if you got neurovascular decay, you just need to get up and dance it away. Seriously, trying to mitigate this decline, it may be all driven by childhood experiences and genetics may define. Alzheimer's disease and dementia is not hopeless, but it's a field filled with the bogus. Maybe light and sound stimulation and DBS will help us, perhaps not forget what you just told us. Monitor your patients closely. It's chronic. We do a slums mostly. And pay attention to the caregiver. Don't let the stress and strain lead them to wither. So this is a somber challenge for us all. So let's just be honest and supportive and heed the call. Peace out. All right, there you go. Walk fast, lift weights, eat like a Mediterranean Sea, all right? Any questions? That's a little different, right?
Hey, what were those middle school grades that were good?
No, any B or A. And I know you're the exception. Yes, sir.
There are some mTOR inhibitors that we used in treatment of cancer. Are those being studied in
Yeah.
Okay.
Yeah, they're going to be part of the menu for the senolytics, the healing the old aged cells that don't go away. I think. I don't know that there's a clinical trial for, it's rapamycin is the main drug, and I don't know that there's a clinical trial for that by itself.
What's the predictive value of excessive somnolence or a tendency to easily sleep, nodding off as you get older?
Yeah, I hesitate to, like I said before, I'm giving you my take on it. You will find articles that excessive sleep is a problem. And I think if you're nodding off and you're doing too much of your day sleeping, it's because you're not getting the high quality sleep. And again, DBS, I saw a paper where they did deep brain stimulator in a person who was an insomniac and restored her sleep architecture perfectly. It's very spooky out there, what's going on. So that's my take on it, Louis. Well, we'll call it a day then. Thank you very much.